session, and we will go from there. Good morning, everyone. Thank you. Welcome to the second meeting of the Oral Health Task Force in Maryland. This is a virtual task force meeting, so I'll always ask for your patience as we resolve any any technological or streaming issues. Before we begin, I remind the task force members that this meeting is being streamed on the General Assembly YouTube channel. Please, you will be muted during this briefing. If you have any questions, use the raise the hand feature and give us a moment for the staff to be able to unmute you. And after I call your name, we will entertain your questions. We will begin today's meeting with a roll call to make sure we have the appropriate quorum, and then we'll go into our agenda, which you all should have present. So let's make sure we have. I have myself, Dean Reynolds.
Here.
Dr. Dow.
Here.
Dr. Kloyman.
Here.
Dr. Hughes.
Here.
I'll try to slow it down for the staff. Dr. Doring. I see Dr. Doring. Dr. Kimbers. See. Ms. Minsky. Okay. Ms. Davis.
Here.
Present. Ms. Russell.
Present.
We have Kranska. Yes, we do. MJ, thank you. Dr. Carlson.
Here.
Dr. Verma.
Good morning, present.
Ms. Bremen, see you.
Good morning.
Morning. Ms. Backley.
Good morning. Here.
Ms. Masden. Dr. Romaine.
Here.
Dr. Woodward.
Present. Good morning.
Morning. Ms. Steck-Waite. Mr. Shiflett.
Good morning.
Ms. Kreese. There you are. Okay. And welcome, Delegate Bagnall. We have a quorum. Folks are present. So first announcement to make, since this came down from the State Ethics Commission after our first meeting, is that on its September 22nd meeting, the State Ethics Commission considered the financial disclosure exemption request from the Task Force on Oral Health in Maryland. The Commission has approved the request for an exemption, and as it concluded, the task force functions in an advisory capacity only, and there's no other compelling reason to require disclosures. The mind of the task force remains subject to the requirements of the ethics laws, including the conflicts of interest found in Subtitle 5. Are there any questions regarding that? Okay. Before I go on to the rest of this, Dean Reynolds, do you have anything you want to start off with before we get into the agenda?
Thank you, Alex. No, other than to thank everyone for joining this morning. I look forward to our discussion.
Thank you. So the first item we have on the agenda is consideration by the task force to move to more frequent meetings, given the mandate in front of us and the sizable work plan that we want to execute upon. I know that might present professional conflicts vis-a-vis your clinical practices and so forth, as well as other professional encumbrances, but wanted to present that after conversation with the staff as well as the task force chair. We would like to make the recommendation to the task force that we meet on a biweekly basis. So it would still be it'd still be a Thursday. We would still retain our the third Thursday, but it would be the first Thursday and then the third Thursday of every month, and try to keep that cadence, at least in the beginning, while we get some legs around the work that we have involved given the fact that we have an interim report due again in May, June, and then the final report due at the end of next year. Time goes by fairly quickly. We also have session coming up, which distracts a lot of the staff and operational folk, given the demands of that time period. But before I posit that to the task force, I do want to make note that we have made some inquiries with the legal staff regarding the use of proxies. And so the advice of legal counsel has been that we are well within the parameters of the enabling statute and existing case law and regulations to meet more frequently if we so choose. And secondly, that proxies, that is somebody to act in your stead should you not be able to attend a meeting, are permissible with two caveats. Number one, while this person may be a seat at the table and represent the interests of your organization or entity, they do not count towards a quorum, nor may they vote. So in recognition of that, we would obviously defer votes and preemptively notify folks about votes that we will take to make sure that we have the appropriate quorum as well as the lead task force members present for that. So if you're unable to attend, if we decide that we're going to go to a meet every 2 weeks in order to accomplish our large task at hand, proxies are permissible, but they do not count towards a quorum and they may not vote. Obviously, these meetings are recorded and such so that you'll able, between the proxy taking notes as well as the materials online, as well as the recording, you'll be able to, there'll be full transparency as to what happened at the meeting that you were unable to attend. So with those corollaries and with that information presented to everyone, I wanted to open it up for conversation and then take a vote on the motion to meet this task force to meet on a biweekly basis. Dr. Kooiman.
I'm fine with doing that. I do think it's a little bit difficult for some of us that are in clinical aspects of care, just because we have patients that have been booked out so far. Would it be possible to do those other meetings that we're adding after hours, say starting and doing from 5 to 7?
I mean, that obviously it would be something that we would have to take a vote on as well, so we could entertain that. But let's I don't know what the ability of the task force is, staff to support that and so forth, but I'll hold on to that. Dr. Hughes.
So is the plan, would you like to begin these additional meetings in November or December?
Begin them in November.
So I think if, because we are so close to November, it might give people a little more chance to adjust their schedules if we start in December. That's an option.
Absolutely.
Alex, did you want to mention the possibility of holding votes only on those dates that have already been identified so that members who have planned and are available will be present?
Yeah, that's what I had led to when I made the point about the what we received counsel, that the votes would only be present with the meetings where we would identify those meetings in advance and obviously make sure that those would be wedded, if you will, to the standing meetings that we have in place now that everyone is already committed to on the third Thursdays. Dr. Verma.
Thank you. I think we have the same issues in that most of us have, I can speak for myself only. I'm in clinical practice. I'm serving as chair of the Maryland State Dental Board, which involves multiple meetings a month, and adding an additional meeting to this makes it a bit of a challenge. I guess I'm curious as to how many people would require proxies to attend and whether that will affect our quorums during the meetings, because it's likely that I will probably need a proxy for some of these meetings. I had made plans for the meetings that we had been advised of, and this is a significant uptick from the number of meetings that we had originally planned. So as Dr. Hughes has mentioned, I think we need some time to adjust, but I am curious as to whether or not we could take a poll to ensure that we have a quorum at these meetings, because it is possible that we have multiple people in need of proxies.
Fair point, Dr. Romain.
No, I would say as a clinician, perhaps a place of flexibility could be having the meeting go over the lunch hour, like an 11 to 1, or at the end of the day, like a 3 to 5, where it would still be within the hours of the staff coverage, but maybe wouldn't take 2 hours out of our clinical day, just 1. So that would be a compromise I would like to offer for the group.
Well, I'm gonna proffer a suggestion here in a moment, but I want to make sure I don't prematurely quash suggestions. So let's keep this open for a moment so I can take on some additional suggestions or comments. Okay, hearing none, what my suggestion is, hearing the feedback thus far, is given the fact that we will, again, need to have a quorum, and if a proxy cannot act in that proxy, then we would have a difficulty in conducting the course of business. So given the fact that we have a fairly full agenda today, what I would suggest is this. My suggestion is that we come back, we'll approach you all with a poll about who would probably require a proxy if we were to move to the multiple meetings. Once we have crossed that threshold, if there's just too many, then it doesn't even need to go to a vote, because we wouldn't have enough folks to sustain multiple meetings. If we would have enough in order to maintain a quorum, then I would, the second question that we'll pose to the task force members is asynchronous meetings in terms of during the lunch hour, after hours, if people would be amenable to that, and then we can go from there. So pending getting that information, feedback from the task force, I would suggest that we wouldn't be able to even move forward on multiple meetings until December. So I would defer pending more information about multiple meetings for another month while we capture that information from the task force members to see if that's even a possibility. Does that work for everyone? Okay, Dr. Doran. Can't hear you, sir. Or task force members.
Yeah, thank you. Maybe as a compromise, we consider maybe a 4 to 6 on a Thursday evening, so we're not keeping staff too long, and we would be probably canceling one clinical appointment or hygiene exam. Just throw that out.
I appreciate that. So we'll capture some information from the members to make sure that we can accomplish this. It might not be something a bridge too far, but again, given the amount of work that is ahead of us, and we'll be starting to address that here shortly when we talk about the work plan. We do think that it's probably prudent to have multiple meetings, but again, we'll defer that while we capture information. Before we get into the work plan to discuss, which should take up the bulk of the information, or a day rather, I will note that we do have 2 capstone presentations at the end of our time, or after we've had a chance to discuss the work plan from the Office of Oral Health, as well as from the Medicaid staff here at MDH regarding the Healthy Smiles program, which I think will be informative to our deliberations and build upon previous presentation by the IRD staff here at Medicaid. So I do want to say that, make note that we've would like to try to get to those presentations today, but obviously we have to take things in order, and consideration the work plan, the kind of seminal document, operating document is key. So with that, I would like to turn our attention to the Maryland Oral Health Task Force work plan, which you have been presented with. to open it up for consideration, amendment, and so forth. And in development of this work plan, I would make note that we heard all the various feedback and concerns from staff, or from task force members rather, during our first meeting, and have attempted to divvy up the areas of inquiry into a certain flow. And don't know if Dean Reynolds wants to speak to this a little bit more after I finish my point. And it is our thought, as part of the execution of this work plan, that we would divvy up a lot of the work with homework assignments, for lack of a better word, to various task force members to follow up on with support from the staff, rather than breaking into 9, 10 different subgroups, and do the bulk of the work in the Harvard with the larger task force, so that people can come back with the information and we can have our deliberations in this larger group setting. That's the thought. We've kind of gone back and forth on what we think would be the best structure for our deliberations and consideration of evidence and so forth, and have a meaningful dialogue that is also transparent. And so that is the idea that we have come up with in the framework for this work plan. Dean Reynolds, would you like to add to this?
Alex, no, I think that really captures nicely. Did you want to go forward with the direction, or the proposed direction of the effort?
Yeah, so the work plan that we have in front of us, and I don't know if it again has been posted to the website, and you all should have, I don't know if our staff can present and put this up for everyone to see simultaneously. That would be appreciated. Just briefly, we'll go through it, and then we can open up the dialogues. If not, everyone should have it present for yourself. Oh, thank you. Thank you, Lindsay. So the areas of inquiry, in terms of the flow, if you will, revolving around the targeted populations. Who lacks access, what the quantum of access should be, the targeted populations. So the populations that we've identified, and these are just, again, this is the first sketch, if you will, that we want to enhance their and complement their existing access to dental care. So these are the targeted populations. Once we are considering the targeted populations, we're also considering amongst each of them the various barriers to access, whether they be geographic, racial, ethnic, socioeconomic, insurance limitation, access to practitioner workforce, education and outreach, dental literacy, if you will, in order to inform recommendations and suggestions to address each one of these discrete populations. And so the flow starts with the conversation of taking on a particular targeted population, then screening them against the various barriers to access to care, and then developing recommendations thereto. So, if you will, the first bucket of targeted populations of care flows, then each one of those flows to the barriers for consideration, and then therefore flows down to recommendations and suggestions. So just to give you a sense of how these cascade to one another.
And if I may just interject, it also, this flow allows us to analyze the specific impact of each barrier on a particular population. And I think will help us as we look for options to eliminate the barriers and make recommendations.
And to that end, thanks, Dean Reynolds, I would make note, this appears to be the appropriate time to point this out. You should all also have access to a library, if you will, of resources. And we've begun to populate that with various data points, data sources, and they're organized to help inform the homework, if you will, and to help to inform the consideration by the task force members and the subgroups, if you will, of the task force to address each one of these populations. Obviously, each one of these distinct populations requires its own set of data or own set of resources that will help to flesh it out. But this is the beginning, the baseline of that library we've established to provide folks some grist, if you will. Dr. Dow, you have a question?
Thank you. So I'm wondering if it would benefit MHEC, our colleges, to clarify when we talk about education and outreach, and maybe separate them into kind of two different components. So my suggestion would be, are we talking about education and the process of expanding the workforce? Or are we talking about education in the context of outreach and educating communities and individuals about the importance of oral healthcare and how to navigate different systems? So I think education should be split into kind of two constructs, one around workforce and one around outreach. That would be my suggestion.
Great. Oops.
If I may just add, I fully agree, and I think this was a first pass just to begin to articulate barriers that I think we collectively agree are important. It will certainly be expanded, and the value, again, is being able to align that with who's impacted and how might we minimize that barrier.
Thanks, Dr. Dow. Dr. Dow, thank you for opening the conversation. So at this point, you have a sense from the dean and myself about how we structured it with your feedback and with your suggestions from the first meeting. So I will open it up to considerations similar to Dr. Dow's about where things should be. There are things that are missing, things in terms of amendments, amending the work plan, suggestions to more particular areas of focus. So I will begin to open that up. Christy, please.
Thank you. So my comment is actually more of a semantics comment, but I am hoping that we can change under targeted populations access to care, adults with special needs to say adults with disabilities, including intellectual and developmental disabilities.
No.
Thank you. Dr. Hughes, and at this point, staff, if we can go, Lindsay, if we can, this way I can only see five little windows at a time. There we go. Thank you. And at this point, everyone should have a hard copy of this. Dr. Hughes.
So on that note, could we put those patients in a single category, leave adults separately to and for special needs to include the pediatric patients as well?
So pediatrics, adults with special needs, and then
no,
pediatric special needs?
Pediatric and adults with special needs.
So should we have just a pediatric, adult, and then a special needs population 3 rather than 5?
That's what I'm suggesting. Yes.
But again, please omit the special needs and,
yes,
and strike that completely and include adults and pediatrics with disabilities, including intellectual and developmental disabilities.
Yes, thank you.
Thank you.
And how about elderly?
Dr. Romain.
As much as I usually agree with my good friend, Dr. Devaney Hughes, on the point of bringing together children and adults with disabilities and special needs. I had a Downs 32-year-old just yesterday, and getting him care is a much different thing than trying to get care for a Medicaid child. So I do think I am loving the grid that you have developed. I think it's so perfect because it leaves nothing unturned. And I do think adults with special needs and disabilities need their own time and thought of this esteemed group to solve big problems that they have with access to care.
So then hearing this, I think it might be worthwhile then to do adults, children, adults with special needs, including children, pediatrics, no? Okay. So.
No,
Chrissy,
we're not using the word special. needs.
Yeah, we're
Okay,
striking
okay.
special needs. And then to Dr. Romaine's point, I think the other piece to that is to consider that transitioning youth population who are moving from pediatric care into adult care. I think to your point, Dr. Romaine, that's where we find that people with disabilities, specifically intellectual and developmental disabilities, have the hardest time because pediatrics tend to get more training and information about developmental disabilities specifically than adult practitioners. And so just another point to make, I don't know if there's anything that this task force has to offer on that, but that transition period from moving from pediatric care to adult care could potentially, if we're able to provide information about developmental and intellectual disabilities to dentists, that may help that transition and help with the adult population.
I think we're all done.
Should adolescence be another category in and of itself, or is this just for the purposes of that overlap in pediatrics to adult?
So I agree with Dr. Romaine that it's different when you're caring for an adult with a developmental or intellectual disability than it is pediatrics. I think pediatrics, and correct me if I'm wrong for all of the dentists on here, but there tends to be more training for pediatric practitioners when it comes to developmental disabilities. And so I don't think that adolescence needs to be separated from pediatrics, but I do think that it's worth maybe a conversation or some research just about the information and training that's offered to adult practitioners with regard to people with developmental and intellectual disabilities. But that also needs to start in that at that age range where pediatrics need to move from pediatric care to adult care.
Other folks? Dr. Romaine, you still have your hand up? Please.
No, whenever I see the Medicaid covered populations, that in my mind is the adult Medicaid covered populations, right? So just to talk of the purview of our task, are we tasked with looking at, say, adults with insurance who already have access or not? Because that would help us to kind of put this down. Like for me, pediatrics, adults with special, or I'm sorry, I'm sorry, the wording, with developmental disabilities, elderly, Medicaid covered adults or children, because that too is a thing. Like to me, the Medicaid covered population needs our biggest attention looking through the lens of adults.
So Medicaid, I would note, and this will be part of the conversation that our Medicaid staff presents after we've concluded our conversation about the work plan, are eligible categories of individuals. So they have they are beneficiaries based on their eligibility category, age, where they reside, income means, so on and so forth. Very discrete, distinct, yes or no. In terms of the population. So some pediatric groups will fall into that, some will not, depending upon their eligibility category. So we keep them appropriately separated for that purpose, since pediatric population would have, if Medicaid is covering their Medicaid beneficiary, they'll have certain coverage options. I would also invite, obviously, Delegate Bagnall to interject into this conversation as well. In terms of the charter of the task force is not exclusively focusing on Medicaid. Medicaid plays an extraordinarily large role in this conversation, given the means of coverage, again, which we'll explore more in terms of the presentation later on, and as well as the populations that we serve But we are not exclusively focusing on Medicaid for the purposes of oral health in Maryland. That said, we also have certain practical restrictions. We cannot affect Medicare's design on dental health because that is a federal program which the state does not dictate, nor can we effectuate what a Medicare Advantage plan offers in terms of the quantum of their dental benefits. Our relationship in Medicare only exists insofar as we coordinate with dual eligible SNP populations, but that is not related to their benefit design per se. In terms of insurance, if we want to explore the barriers to access as part of that, which is the insurance conversation, then suggestions could be made in terms of what we do require or not require of insurers in terms of what they offer. But as we've done some of the pre-leg work with regard to the Maryland Insurance Administration, found that the dental benefits let's say as a proxy, the smaller individual group market are all over the place. There's no standardization to that. And so that becomes a little bit more difficult to define or circumscribe. And we can have additional conversations and additional speakers come to inform that conversation. So we have a larger aperture, but we don't want to boil the ocean. And we also have to take into consideration there's things that we can affect because, again, the stakeholder audience for this task force report is the legislature. They will be responsible for passing legislation or informing us vis-a-vis where we want to be able to change regulations and, quite frankly, finding the money for it all. And so that's where we land. Dr. Koyman or can we?
Sorry about that.
No worries.
I actually like the way that you have it set up now. I think it's better to keep these categories as broad definitions rather than starting to break it down into like smaller groups, because I think if you do that, then it's gonna I think things break down further and further. I mean, then I think we need to start, talking about, I mean, you could get to the point of, people that speak English as a second language, people that maybe are LGBTQ children and adults. And so I think just by having the headings be, pediatrics, adults, and then maybe another one that's just, people with, disabilities, and keep them broad. I think that way, when we discuss these, then we have to kind of bring all those topics into it. But I think if we go down and start trying to parcel out each one of them, I think it's going to end up making it, pretty weirdly more restrictive as far as the list goes, as opposed to keeping it more open, is my 2 cents.
Thank you. Delegate Bagnall, please.
Thank you. I just wanted to sort of tag on to what you said, because I do think we want to be careful about not getting too in the weeds with this. A lot of work has been done around the Medicare and Medicaid market. And so we don't want to sort of fall into survivorship bias, where we're singularly focused on issues that we have been working on, which is, I think, why we were trying to have, to paint with a broader brush. And when we're talking about, how strategically we want to operate, there really are sort of 3 paths. There's corporation, regulation, legislation. And ideally, legislation is the last thing we want to do, because it tends to be the most prescriptive and the least flexible, because once you put it in law, if you want to change it, you have to go back and you have to change the law. So I think as we're looking at this, we want to look at those sort of 3 buckets of how can we meet these needs and address these gaps in services through cooperative efforts, through regulation, which gives us more flexibility, and then finally through legislation, if it really does require a legislative fix.
Thank you, Delegate. And again, this is the in terms of our deliberations, it's the clue: who, what, how. Our populations, what do they need? How do we get there? And to Delegate Bagnall's point, can it be amendment of regulations? is it new legislation? The vehicles to accomplishing that are varied, and at the same time will be pretty easily to define once we get to our recommendation, because there's only certain ways to do things. And we'll explore those as we as we go through the process. Other questions? Dr. May, do you still have your hand up? You took your hand down. Not seeing any other hands.
Alex, if I may just interject, based on the legislation which speaks to residents affected by poverty, disabilities, or aging, I would recommend that we maintain a category for elderly, at least as a first pass.
Absolutely. Maintain it with the recognition that we have certain limitations insofar as dental is or is not, and presently is not, that may change in several months, covered by Medicare. But for obviously a population that we focus on, especially when as it relates to perhaps duals population, where Medicaid then does become a factor vis-a-vis the quantum of benefit that may be offered. So now I'll kind of bring it back to the, and we'll figure out the semantics in the labeling, bring it back to a larger group question of what are we missing? Is this rubric, is this framework large enough to capture the broad mandate of our task force, as well as the individual inquiries and stakeholder concerns that you all represent? Dr. Romain, please.
I believe it is, and I believe it's done so in a very logical way, where as the report is being read by others and they have certain issues where they want to find answers, I think this logic to the organization is going to give them a good place to access the answers that they need. So I think it's very well thought out, and I think it does fulfill every possible situation.
Dr. Hughes?
I would agree with my colleague, and I think the list is very inclusive and it gives us a good start.
I'll also posit that also extends to the barriers to care. So unless we want to address those.
Would you mind sharing your screen again? Is that possible? Because I don't have the hard copy.
Lindsay Tyler, please. Thank you. So give you folks a point in time to digest and contemplate, and then comment. Dr. Hughes, please.
So does geographic include lack of transportation?
It can. I would suggest that we probably would want to break out a little bit more separately. Geographic to me would intuit rural versus urban, which naturally implicates transportation, but we could, it could be either embedded as a sub to that geographic access, or we can break out transportation as its separate option. But I would make the note that is my suggestion, if we do break out transportation as a separate barrier, that we don't then start going down a very particular and detailed checklist of childcare and so on and so forth.
Okay.
And if I may add, we will likely want to go back to the legislation because the barriers there are barriers that are articulated in some of those cluster, for example, under education. But there are others, such as language, cultural barriers that we'll want to be sensitive to.
Dr. May?
I agree with earlier, a colleague was talking about education related to workforce, which I think, is kind of a automatic. Of course, we're going to discuss workforce education, but the last point, I think, as she had so eloquently said, and I would agree with her, that outreach to the public needs to have kind of just a better wording. I think if we do that, what you have is really going to function well. So I'm not sure what that wording should be, but just that last point would focus on outreach education to public as opposed to dentists or practitioners.
So yeah, I would, while they are broader categories and standalone by themselves, these single words encompass a lot. The education meant to public education awareness, right? And it's as we see some of the data you'll see in the presentations here shortly about recognition that I'm entitled to, or I might be able to access the Healthy Smiles program, but maybe I don't know about it, or the various, in Dr. Hughes' presentation, the various local assets and resources and clinics that are in my neighborhood that I might not be aware of that I can access. So there is so the education component can be the public education component, and the outreach can be targeting and creating awareness for those targeted populations.
If I may, I think the awareness is not only of the programs available, but of personal healthy behaviors, educating on healthy behaviors, which I'm sure we'll see in the presentations as well. So it's kind of two ways as far as how to actually logistically sign up for Medicaid or find a dentist that would handle a person with disabilities. And it would be education on things like how much sugar should I be drinking, and just the basics of health.
And that'll be that's the kind of the general scope of public health, and Dr. Hughes can speak to as during the conversation. Let's go with Dr. Carlson and then Dr. Kimbers. Dr. Carlson.
Good morning. I'm here representing the community colleges of the state of Maryland in terms of the dental programs that we provide. And I just wanted to say that I actually happen to teach at Chesapeake College the portion of our program to the students concerning people with disabilities. So we are trying, at least as far as I am concerned, on an almost daily basis, we do try very diligently to educate our students as to awareness of people with disabilities and how to best help them achieve optimum dental health, so oral health. So we do have that on our radar and have had for many years. We do have a great need of dental assistants. I've had many people reach out to me saying they're looking for more staff. So we're trying to expand our program. The other thing I just wanted to make a comment about was being here on the Eastern Shore, those barriers to care. I'll tell you what, all of those pretty much apply to folks here on the Eastern Shore. When I first became a Healthy Smiles provider in 2008 or so, there were the children that were coming to me, just volumes, just masses of kids. And now I think that we've got many more Healthy Smiles providers here on the shore, and we're really getting things much better in hand, at least for the children. Dr. Romaine, I did want to reply to what you had to say about your adult with Downs. I just retired some months ago, but in my practice, I saw many adults with disabilities and took many of them to the hospital in the OR. And there were very few people who felt comfortable, who felt that they had anywhere near the skills to deal with adults with disabilities, nonverbal adults, just all kinds of issues. that I think is a major area of where maybe we are lacking in the training of our students. So it's something that I am going to make a point of putting more emphasis on in my educating of my little part of the world with dental assistants, but maybe at the dental school, we can evaluate, to kind of take a look at how dental students are trained to deal with adults with disabilities, because I see that as being a big need, a major need. Those folks are definitely underserved. And Ms. Russell, thank you for pointing out the people with disabilities, identifying those folks in that way, that the special needs has kind of gone by the wayside. Thank you for making that clear to everyone. Thanks for letting me speak.
Of course. Dr. Kimbers.
You can hear me now, I think.
You're good to go.
All right. Good morning, everyone. I just wanted to say that I think that geographic is kind of synonymous with transportation, and especially what Dr. Carlson was just saying, in a rural area. It's hard to get certain places, and especially with specialists, they just aren't there. And you could have a transportation / geographic issue even in an urban area where there is not good transportation. And with things being cut back, like the bus system, and as we saw during COVID, certain lines of the bus lines, they were cut back. So I think that transportation should go with geographic as a /. That's just my opinion.
We can certainly embed it in part of that instead of punching it out separately in recognition that they, again, go hand in hand.
Dr. Kimbers, that's actually the bill speaks to geographic or location of dental offices focusing on lack of transportation. So you're very correct.
Dr. Hughes, and then the delegate, please.
So I'm not sure where this would fit, but we have not discussed the LGBTQ plus community. So I'm thinking under barriers to care, would it be cultural competency, or should we include them as a targeted population?
Well, in taking the LGBTQ population, for example, in the purposes of Medicaid, any Medicaid provider that accepts Medicaid money may not discriminate based on race, national origin, sexual orientation, or gender identity under new rules that will be promulgated by the federal government forthcoming. And so any kind of barrier from a provider specific perspective in Medicaid is mitigated by federal regulations and state regulations. But in terms of cultural competency with regard to education, outreach, and targeted populations, are they not receiving dental care, or are they not able to find providers who are again culturally competent to that population? I think there's two different questions, whether it be access and service.
So the reason I bring it up, one of our initiatives that I will discuss later on is a pilot project to increase access to care for that population. And in our focus groups, we have found that there are issues with seeing certain dentists who are not culturally competent. And so that's why I think that it's certainly something, it is a barrier to care. And this is something that we've identified through these conversations. And so that's why I wanted to make sure that it's included in one of the categories.
Delegate Bagnall, and then Dr. Goring.
Thank you. Dr. Hughes and I were sharing a brain just now, because I was thinking along the same lines, and I did go back and look at the legislation just to make sure we were encapsulating the language of it. And I think cultural competency is one aspect that is spoken to, and the other aspect that I'm not sure whether it would be under cultural competency, under racial and ethnic, but was also the barrier of language. And when we're talking about workforce, there's also, I want to make sure that we're encapsulating with that, you know, are the hours of operation conducive to the communities in which they're operating? Because, and I think that that is under work. I think we can encapsulate that under workforce, but that was actually a question within the bill to determine if one of the barriers is availability is the community that is we're meeting the need.
Thank you, Delegate. Dr. Doring.
Yes, I just wanted to remind everyone that the legislature this past session passed a cultural competency course that will be required of all healthcare providers, and the state's currently working on that course. And that's one that's going to be required by the State Board of Dental Examiners for all licensed dental practitioners, the dentists, dental hygienists, when they renew their license. Also, just to state that the Maryland State Dental Association, very aware we have a diversity and inclusion committee, a full-blown committee, and at the Chesapeake Dental Conference in September, we held a very exciting course on diversity and cultural competency. That included LGBTQ. So we're well aware and we're working in that direction. So thank you.
Dr. Verma.
Thank you. So as Dr. Doring has mentioned, there is a cultural competency requirement, but there's also going to be an implicit bias training that the state board has promulgated in regulation. We are still awaiting the final approval of regulations, so the exact time frame of when providers will be required to ensure that they've completed those is still in flux. But I wanted to make everyone aware that both of those are coming forward in regulation for all licensees through the state of Maryland.
Great. Other comments? I'm going to assume Dr. Doring and Dr. Verma, our hands are down because your hand should be on the wheel. So we will go. Anyone else? So you're now viewing Lindsay's screen where she's been making in real-time edits per our suggestions to the task force areas of inquiry. What I would, yes, thank you, Tyler. What I would, those of you who do not have access to view it right now, we'll actually ask you to look for it when we send it around to the task force members. Well, at this point, unless anyone else has any additional conversation to the work plan, I would put forth a motion to accept the work plan with the edits. We will circulate that back around to make sure that we captured everything appropriately, including the semantics. But I would ask that we get a motion to proceed and to approve the task force work plan. So I'll leave it up on the screen, and I don't know if we should just do a roll call or see if there's anyone has any objections. Task force staff, any suggestions? Because I don't. Should we do a roll call for this, or should we just ask and see motion to proceed and then have it seconded, and then if there's no objection, it will proceed?
Yeah, you can just do a voice vote.
All right, we'll do a voice vote. Motion to adopt the work plan as amended.
I second it.
So moved.
All in favor, say aye.
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 Thank you for the chorus. And all those who object. Okay, thank you very much. So approved. We will circulate this around to the task force members for your review to make sure that we've captured everything appropriately. We will proceed from there. Before we jump into our presentations, I do want to again make note of the library of resources that we have available. Now that we have the work plan in hand and approved, we will start to populate and put forth additional resources as we find them to help inform the task force members as they go through. In terms of the homework assignments, as for lack of a better word, what I would suggest is that we'll work with the staff to get a poll to the task force members as part of our conversation about increasing the frequency of our meetings to find out where people would, what areas and what domains they would like to participate in across the targeted population's access to care. That way we have open it up for participation from all, and then again that will flow to the various access. So rather than trying to do that now and take away time from the presentations and also the opportunity for public comment, which we have made note is going to be part of every other meeting. I don't know if we have any public comments for today. I will defer on that association of task force member to each area of inquiry for after the task force meeting, and we'll do that with communications with you all if everyone's supportive of that, rather than doing that right now from an administrative task perspective. You also feel free to email us about your interest, but we'll frame that up in our follow-up conversations with you all. Does that work? Outstanding. So with that, we have two presentations today. We have presentations from the Acute Care Administration here at MDH, as well as from the Office of Oral Health. And I believe that we have Katie Narrell, the Deputy Director of the Acute Care Administration, on to present. And I believe the staff have her deck, and if you could help her manage that on Zoom, I would appreciate that. And Katie, please feel free to introduce yourself to the task force.
Thanks, guys. Can everyone hear me? I can't always hear myself on these calls. So hopefully I'm set up well for you guys today. Thank you so much, Alex, for inviting me to come here. It's great to sit in on this meeting and see many familiar faces. I know several of you from working with the Maryland Medicaid dental program in the last few years. And so it's great to be here today representing the Maryland Healthy Smiles dental program. For those of you that don't know me, I'm Katie Narrell. I'm the Deputy Director for the Acute Care Administration here at the Maryland Department of Health. And the Acute Care Administration manages a wide variety of fee-for-service Medicaid programs. So dental is one of our big ones. I have a wonderful team of dental folks that work very, very closely with some of you, with Skyjen, with a lot of the stakeholder groups in the community. They're pretty active out there. And unfortunately, I tried to get Claire to be here with me today to present. Claire Serio is the division chief for dental and the contract monitor for Skyjen's contract. So she was unable to be present today. We had to divide and conquer our meetings. But she runs a very tight-knit team that works very, very closely with Skyjen to ensure that we we administer appropriate dental benefits throughout the state of Maryland, not just for the members, but also for the providers that enroll in Maryland Medicaid. So if you want to advance the slide deck, just very quickly for those of you that don't know, the Maryland Healthy Smiles Dental Program is Maryland Medicaid's fee-for-service dental program. And here in Medicare, or here in Maryland, we carve out our dental services. So that means that they're carved out from the managed care organizations. So all children, regardless of if they are enrolled in a Maryland or an MCO, a Health Choice MCO, managed care organization, they're eligible for dental benefits through our fee-for-service dental program. And a lot of folks are becoming more eligible for the program. We're adding coverage groups every day. We have children under the age of 21. We cover dental benefits for REM children as well as REM adults. That's the rare and expensive medical program, that case management program that's run out of the coordinating center. Many of you are probably very aware of that. Pregnant women are covered for dental benefits, as well as women in their postpartum period. This is a new benefit. We're really excited to see this being launched here this fall. And more to come next year as that postpartum period gets longer and longer in our definition. We're going to extend postpartum benefits for up to 1 year after the woman's pregnancy ends, as of, I think, April 1st of next year. Back in 2017, we added former foster care adults up to the age of 26. And back in 2019, we launched our adult dental pilot program for adults aged 21 to 64 years old, and they must be dually eligible, so Medicare and Medicaid eligible. And once again, we work with Skyjen USA. They're our dental benefits administrator at this time, and we work with them very closely to have good benefits being administered throughout our state. Next slide, please. So what does Skyjen do? What is their role? Basically, we brought them on. They're our second dental benefits administrator. And we brought them on to help us. We don't have nearly enough folks at MDH to run the dental program. So they help us out. They do a lot of different things. They are in charge of managing the network, outreaching to providers, bringing them in, doing provider and member outreach and education, both in terms of what are benefits, how can you utilize our system, and they do a lot of outreach events. That certainly has changed quite a bit in the state of the state in the last year and a half. But they're launching more virtual outreach campaigns at this point in time as things change. They assign all of our participants to a dental home, and that is to be able to assist and ease the transition to new folks who just come on that may have not had a dentist in a long time. It gives them a starting point. Skyjen has a bunch of clinicians on staff who are in charge of pre-authorizing certain services. They also, sometimes we have folks show up at some of your doors and they audit providers to make sure that things are happening the way that they need to happen with Medicaid services. They're really looking at increasing the program integrity that we have in place. Skyjen's been looking at utilization of benefits. Right now, there's a big push to target members in the adult dental pilot and utilization of services there to increase that. They also manage a complaints and grievance process for both providers and members alike, and they collaborate a lot with our stakeholders. I don't think most of you guys probably have had some contact with them. Dr. Koyman here is actually their Maryland dental director, and he helps us out from time to time, talk about what makes sense in our state and with the population that we serve. And Skyjen also puts together member advisory boards that meet on a quarterly basis, both for members and providers. There's a couple other folks here. Dr. Kimbers and Dr. Doring is a more recent member of our provider advisory board. So it's great to see them in a different forum. It's great to see what the task force is looking to do. And we hope that here at Medicaid, we can partner with you to make our side of dental care in Maryland better. So just a couple stats on the adult dental pilot program. As most of you know, the pilot program began on June 1st of 2019. And it was a bit of a rocky start, but we got folks in there, we got them enrolled, got the message out to folks with welcome packets and flyers and all kinds of good collateral that Skyjen helped us put together. The strange thing, the different thing for Medicaid and running this pilot program is it doesn't function like a normal entitlement program that we're used to in Medicaid because there's a cap on services. Because this pilot got a limited amount of money through the legislature. I think we were given $5 million, which was then cut the first year. We had to cap benefits per member per calendar year at $800. Because of this, we have encouraged and asked providers to utilize something called the Global Treatment Plan. And this is really something that is meant to assist providers in appropriate treatment planning, understanding that many of our adults are walking into the dentist, maybe after not having had dental care for the last 10 years. And there could be several different treatments that are needed in order to get that person up to par with their dental care. That may need to be prioritized. $800 may not cover it all this year, but this global treatment plan assists the provider, the dentist, in helping the patient to understand what care is needed, what treatment should be prioritized, and how can we get everything done, maybe over the course, maybe not all this fall, but maybe over the course of the next 18 months, given how the funds are provided for them and where the services are covered. So this chart gives you a little idea of the uptick that we've seen in this program. The number of unique members that are utilizing services every year. We're down a little bit in the last couple of years. I think that's to be expected though, given what has happened with the pandemic and given that providers were unable to see patients for dental care for a little bit of time. But this is also one reason why we are reaching out and working with Skyjen to make sure that these folks understand that they can get back out to the dentist and be seen. And so we've got at this point in time about 7,600 eligible members have reached out and utilized dental services that are covered under this pilot program. There is about, I think, just over 30,000 participants. So while we're doing a good job, I still see that we have a little ways to go. And this is one of the department's big priorities, is to get out to this population at the present time. Next slide, please. Thank you. So we've been working really hard. There's been a lot of talk about things that have happened in the legislature. It was a very busy last session with a bunch of different things, and several things happened here that concerns dental. So one thing that we currently have regulations that were printed in the Maryland Register a month or two ago. I don't remember the exact dates. Many of you probably saw them. We are currently waiting for the notice of final action to be printed in the Maryland Register for 10 days, and then the regulations will be promulgated. Potentially those will be promulgated in mid-November, but do understand that that date can always get pushed back, just barring signings and things like that that have to happen here at the department. But that's our goal. And in these regulations that are going to come out, a few things are going to happen with them. So most of you know about the postpartum dental coverage, which is going to be put in place. The notice of final action will look slightly different from the notice of proposed action that was actually published in COMAR for 30 days. are in the Maryland Register for 30 days. That is because postpartum is currently this fall, when these regulations go into effect, postpartum dental will cover folks for 2 months after they deliver their child or their pregnancy terminates. In April 1st, we will be doing an amendment to our state plan and requesting that we are able to cover the postpartum period through for 12 months after the woman delivers the baby or after the pregnancy ends. So in doing that, we are going to change our language so that in the COMAR chapter that governs our dental services, we're referring back to the eligibility regulations, which is the 1009-2402 for the definition of the postpartum period. That way they can hash out all the legalities of what it means to be eligible in your postpartum period, and we will just refer back to that. But we're super excited to see all these additional people have dental coverage for a longer period of time. It's been a long time coming, and it is your influence at the legislature, some of you, that has helped to make this happen. So we also had another bill that was passed, Senate Bill 485 and House Bill 5487, which referenced the limits that we have on dental cleanings and oral exams. This bill required that, I think by January 1st of 2022, we needed to limit preventative care to no more than once every 4 months or 120 days per plan year. This is a difference from the 6-month intervals that we had required in between your cleanings and your oral exams in the past. So our regulations will change to allow the visits to happen more frequently, but the coverage of our preventative dental care is still going to be limited to twice in a calendar year. But it will allow for a little bit of flexibility given people's schedules, convenience of the visits and things of that nature. Next slide, please. So this is just a little chart that we put together for you guys to see how these regulations are going to be changed and where they are going to be changed so that you have the reference. The first one is for postpartum participants in the covered services section. And the second one is showing you the limits changing for oral exams and dental cleanings. And then this slide shows you a couple other amendments that we're making to our dental regulations at the same time. The first one hopefully is good news for some of you clinicians out there. We heard a bunch of folks loud and clear, and Dr. Hughes was a great resource for us. We're going to change the amount of time that you can have in between your restorations and change it to 2 years rather than 3 if the restoration fails. Maryland Healthy Smiles will pick up that cost again. And the second thing on this slide that we have changed is the pre-authorization, the amount of time that your pre-authorization will be good for in terms of orthodontic treatment. And I don't know if there's any orthodontists on the task force, but in the past, we had all of our pre-authorizations good for 6 months. Doesn't make a lot of sense in terms of orthodontic treatment that is that's on average happening for a year or 2, or even maybe slightly longer in some instances. So we're changing the amount of time that the initial pre-authorizations are required in those cases to ease some of your administrative burden and make it a little bit more in line with the standard of practice. So tele-dentistry has also been, well, telehealth has been a very hot topic in the last year and a half. And with that comes tele-dentistry. I was happy to see tele-dentistry be added to Senate Bill 3, just like many of the rest of you. That bill went into effect on July 1st, right with our governor's easing up of the state of emergency and many of our leniencies and flexibilities that we had in place. So thankfully, this bill comes in and makes it possible for us to continue to allow telehealth services for providers and for our members as it makes sense. in our services. So at this point in time, we have been for the last year and a half allowing and continue to allow D0140 for telehealth services to be covered. That's your problem focused visit. At this point in time, I think that's the thing that we would like to see being done the most, and probably clinicians, you can easily go through the list of dental services that don't make sense to do via telehealth because you must be in the mouth. So at this point in time, this is the only code that's covered. We chose as a Medicaid program not to add additional services to our benefit plans when the pandemic started and telehealth became a thing. This was in part to keep Medicaid from having some serious cost increases based on new codes being added and things of that nature. So 995 and 9996, which have been asked about on several occasions, are not currently being reimbursed today for telehealth services. And this is just a little chart to show you a bit of our claims data. We just ran this, and so we're not having many telehealth claims come through to us at this point in time through Skyjen system. There could be a bit of a claims lag. We understand that you don't have to submit your claims for a year after the date of service, but in terms of this data, it looks like in the busiest months, there were just under 300 claims or 600 claims submitted. On average, about half of the claims submitted for telehealth or teledentistry services have been denied. And we dug a little further into that to see why are they being denied. It's a variety of reasons, but for the most part, I think it's because providers, it's being flagged on an edit for same day, same service. So basically, if you're a provider and you do a telehealth visit and determine by looking in my mouth on video that I need to come in for a service that day, and you schedule me for that day, you will not be paid for the problem focused visit 2 times. I think that is the main denial reason that we are seeing. But it's been interesting to see this data and see the uptick on it. So I wanted to also talk for a moment about our dental reimbursement rates. As clinicians on this call, anybody who is involved with Maryland Medicaid and Maryland Healthy Smiles, you're probably aware that our reimbursement rates are not the highest out there. I think they leave something to be desired on the clinicians end. We hear about it from lots of people in lots of different ways. And I see your face, Dr. Kimbers. I know, we hear you loud and clear on our end. And believe me, it's something that Claire and I, when we get these requests, if we had money in our back pocket to give for these codes, we would increase your reimbursement rates. It's a very tricky thing with our state and with, I think, a lot of states at this point in time, the way that dental reimbursement methodology happens. And a lot of, the good news is a lot of states are looking at that and trying to figure out ways to help dentists out because we feel your pain on this one. I know the ADA just sent a letter. Somebody just sent a letter trying to encourage states, I think, to get to the 75th percentile of the region on rates. And so I don't know what kind of movement that will have in the dental industry, but it is something that's being talked about. So just for your history on Maryland, I think our rates were set in the fee-for-service program before my time, but when the Maryland Healthy Smiles program was carved out of Health Choice in 2009, that's when the base rates were set. In 2015, some of you were involved. The legislature gave a little over $2 million for the rates. But in that, we weren't able to increase rates across the board. A lot of analysis was done, data was compiled, utilization of codes was considered. That has a big impact on what we can raise. And with all of that, only 5 codes were chosen to be increased. So I just wanted you to know that we get these requests, we hear you, but our hands at Medicaid are pretty tied without funding coming through. It's great that we got money for the adult dental pilot. It's great that we're getting money for postpartum women. That's kind of the type of thing that we need on our end to be able to try to help you with your reimbursement rates. But we're going to do what we can on our end as well to help out where we can. And I did just make a note there. Thank you. You don't have to come back, but in our program, reimbursement rates are the same across all benefit packages and for all specialties. My understanding in recent conversations with other states is that some folks do reimburse differently on your specialties. It's not something that I have personally explored. It may be something for discussion to be had on in the future. So this slide will just show you what we were able to do with a little over $2 million in terms of our benefit package. And it's because of the utilization of these things. So notice that just a minimum of $1.40 for fluoride was all of the reimbursement increase that we could give here with 2-point-something million. So we had a larger increase on something like athletic mouth guards, and probably for very good reason at that time. But I just wanted to illustrate to you how difficult it can be for folks to see an increase in reimbursement rates across the program in terms of the money that we get. And then here is another example that has been a hot topic. And we did a big kind of research project a few years back when SDF came up. Dr. Hughes was talking about it, Dr. Corman, our advisory board, a lot of people weighed in on wanting SDF and the benefits of having that. So we did a little bit of research. We talked to some different folks and we realized that a lot of states do many different things, you know, that they're the limits on ages, the number of teeth and applications of SDF that can be had vary from state to state. And the reimbursement rate, I think, varied from anything from like $5 to 30 something. So we did a fiscal estimate for this to say, if we could offer SDF coverage for only the age range of 18 months to 3 years, so just an 18-month period in the child's life, for 4 teeth per year at 2 applications per tooth at a reimbursement rate of $15, what would it look like? We took the approximate number of eligible children, which was 52,000, and said, the utilization states that approximately 30% of these folks are going to go into the preventative care visit and then have the need for something like SDF. So this estimate results in more than 122,000 applications of SDS annually, which looks like almost $2 million in total funds. I lay this out for you guys so that you can get a sense of just how much money is probably really needed to for something to be done about reimbursement rates. And it's something that absolutely, if we could get funds, we are right there with you and we want to increase the reimbursement for Maryland Healthy Smiles providers. One last thing that I wanted to bring up, and this is a topic that we discuss a little bit from time to time. Dr. Koyman, I think you recently brought it back up to Claire, and I know the advisory board with Skyjen, the provider advisory board, talks about it often. There's been, in the last few years, increased difficulty in dentists getting time in ORs. Or times at ASCs, and a lot of it has to do with the hospitals and the anesthesia groups, I think, and reimbursement rates, and the hospitals not wanting to give the time, I think, to Medicaid folks because it's not profitable to them. It's not necessarily something that us at the Medicaid dental program can govern and control, although we certainly want to try to work with stakeholder groups out there if there's anything that we can do to help dentists find a way to take care of the Medicaid patients who need anesthesia, who need OR time, without having to deal with the nightmare that it seems like it sometimes is at some of these hospitals in getting that. So Dr. Koyman, I think that you had a recommendation that maybe involves licensure and different things to potentially get coverage of anesthesia in office for pediatric dental cases. And maybe there's, some adult cases that would also fall into this coverage group. But I think it might be a topic that, whether it's for this task force, whether it's for some of the other, stakeholder groups that you guys represent over time, I know that this has been a pain point that continues to come up on our end. And it really does affect the total care and well-being of the individual when they can't get their dental needs met in this manner. So I wanted to bring that up. And then this last slide is just for additional information. I'm giving you the department's website here. We try to house all of our fee schedules and FAQs and provider manuals, handbooks, and everything on there. Also a reference guide to Skyjen, which I peeked at this week and I think needs updated. They just switched and got a new provider field representative. So I'll get them to do that for you guys. I know that Claire Syria would have loved to be here for this presentation, but was in another meeting. She is more than happy to take questions, help with clarification, or even just good ideas, that you guys have for Medicaid folks along the way. We love to be involved with the community. We love working with the partners that we already do, and we'd be happy to work with anybody in the future on making dental care for Medicaid individuals and folks in Maryland better. So with that, I will conclude. And if there are any questions for me, I'd be happy to take them.
Thank you, Katie. Questions from the task force on Katie's presentation? Christy, please.
Thank you, and thank you for the presentation. My question was really just about when you're talking about, you had the slide about the SDF and preventative care and what the potential cost would be to Medicaid, but are you also analyzing cost savings? And is there a mechanism to be able to figure out if over time adding that money to the budget would eventually save money at, on the back end of things?
Yes, that's actually a great point, Christy. Thanks for bringing that up. We do in our program also try to look at potential cost savings. It's not always the easiest thing to try to parse out in the analysis, but we do have team members who do take a look at that. I believe that when we took this forward as a budget initiative, because we would still need certain money in the dental budget with the state of Maryland, the adult dental pilot program was very new, and they said, please just focus on launching this and getting it off the ground. And so that's what we did. SDF is something that we as a team have talked about, the potential benefit of SDF, especially in the adult dental pilot program, right? Because these folks may be coming in, if you have 10 cavities and $800 will only allow you to get 4 of them filled today, but you're getting more money in 3 months in the next calendar year. Could a bit of SDF being painted on or applied, whatever the correct term is, would that arrest the decay and help that person make it until the fillings, the restorations can be done next year? Unfortunately, without it being on another benefit package, it's really hard to say we're going to put this coverage of a new benefit in adult dental pilot when that's our most limited benefit package. But it's something that I think that we could pull back out in the future as things are changing and as we're looking at future year budgets, Christy, in order to look at all of that and pull that information back out. But yes, we do try to look at cost savings because we understand that that happens. Thank you for the question.
Dr. Kimbers.
Yeah, I had 2 questions about the same thing. When does the benefit start for you had amalgams in there as far as going from 3 years to 2 years if you wanted to redo them? And my second part to that question is you just had amalgam, not composites. And I don't do amalgams at all. I'm mercury free. So does it also include composites? Even though
yes, it does. It does. I think that was just one little snapshot that was pulled out, but all of the references in that covered service section that had referenced 36 months for all of the restorations will be. Yeah, because I think a lot of people do more composites than amalgams.
And when does that start?
So I had ETA of 11/15 on there. The fact is it starts whatever day the regulations are promulgated in the Maryland Register. So at this point in time, because we were waiting on the secretary to sign that, I think he may have done that at his meeting last week, although that's not a meeting that I go to. I can check on that. If he signed that notice of final action, it should publish in the Maryland Register, and 11/15 would be the effective date. But it really does come with the date that the regulations are promulgated. Dr. Kimbers, Skyjen will be sending out a provider alert or transmittal. We will have something sent out to our population as soon as we know when that date will happen.
All right, I know that doesn't have anything to do with our discussion here, but I had to find out.
Yeah, thanks for asking.
Sure, thank you.
Dr. Amin.
Hi, Katie. I wondered if you could speak more to the coverage of in-office anesthesia for children. I want to know more about and have attention, especially related to related to hospital surgical suites being busy. And I certainly would want to not have like a double standard. So I just would like to know from your perspective what that entails. What kind of anesthesia for who in office? Please inform me.
So I may need some help to explain this to you, Dr. Romaine. I can say that in the provider advisory board, we've talked a lot about the dentist's inability to get into operating rooms. So hospitals, I don't know which hospitals are the big ones, but just very long wait times to get appointments, and then the availability for these folks to get in, it's just few and far between. I thought at one point I was hearing that the anesthesia groups were requiring additional documentation that may or may not be a normal thing to have to do ahead of time. And I thought I heard at some point in time that they were even trying to charge Medicaid dentists to go in. We have some other dentists who could speak much better to these things. Maybe Dr. Kimbers is raising his hand about this. I know he sits on the board, and Dr. Koyman may know.
Yeah, I can fill in the gaps there.
Thank you.
Yeah. So the issue with in Maryland is there's been a lot of pushback from hospitals recently because the reimbursement rates for seeing these dental cases for anesthesia is really low. And so the cases take a long time, and so it uses a lot of OR time up, and they don't get well reimbursed. And so this has been a slow moving coup, if you will, where more and more pediatric dentists are being forced out of hospitals. And so looking at those children 0 to 3 years of age, or those children that have developmental disabilities, are not being able to see in an OR setting. And so what's happening is a lot of pediatric dentists are also trying to push the limits more and more with trying to do more treatment, with oral sedation in office on kids that perhaps should not be being treated as oral sedation, as we've seen in other states. That's when bad things start happening in dental offices with children that expire and things like that due to complications. So the thought process can we start having providers, anesthesia providers provide in-office GA or sedation on children to kind of start to begin to help with some of the increase of access to, general anesthesia and to help providers. So nothing's been done yet. I mean, this is still something that, hopefully can come out of it. But I think as hospitals more and more keep shutting providers out, it's getting, and Dr. Reynolds can possibly talk about it at University of Maryland too. The length of time for a kid to be seen in the OR, starts to become 6-9 months, a year. And it's just, that's, the fear that we have is that, something's going to happen to a child because they're waiting, so long for these cases. So again, nothing's happened yet, but it's something hopefully that we can move towards.
Thanks, Dr. Koyman. So I would ask at this point, so we make time for Dr. Hughes' presentation, that if you have any other additional operational coverage issues with regard specifically to the Healthy Smiles program or Medicaid, to reach out to Katie or Claire. Most of you have their contact number, information rather, and it's also on the deck that was presented to you. I will make note at this point that we do not have any public comments in the queue, so the residual time that we have left will dedicate to Dr. Hughes' presentation, as well as entertaining questions there, and then tee up our next action items for our following meetings. So thank you, Katie, and let's turn it over to Dr. Hughes, please.
Great, thank you, Alex. I'm delighted to be here today to share with you the two sides of oral health, as I call it, pre-Diamante Driver and post-Diamante Driver. His death, it changed the trajectory for oral health care for children. I'm not on that slide yet, okay. The trajectory for oral health care for children in this state. And Maryland has served as a model for the country. I applaud our advocates and legislators for recognizing the need for a refresh, and that is why we are here. You can go to the next slide, please. So the Maryland Department of Health, Office of Oral Health, we serve as the leading public health organization supporting and promoting good oral health for all residents of Maryland. As you read our mission and vision statements, you may say, wow, that's ambitious. And how do you plan to do that? And I would say we are building partnerships and collaborations throughout the state. So together we can approach one tooth, one person at a time. Next slide, please. So let's take a look at how the Office of Oral Health has transformed. From its inception in the early 1950s, with little to no resources or impact, to the current, with legislation that has included the Oral Health Safety Net program, requiring a licensed dentist to provide public health expertise for the state. Our office currently has 14 staff employees that include a deputy director, program managers, physical staff, an evaluation and surveillance program manager, and administrative staff. So you can see it's come quite a long way, and we have significant support from our administration. It has been slow, but for sure the trajectory for support of the oral health is in the state. Next slide, please. So during this improvement phase, there were definite warning signs that indicated a need for change. As I mentioned before, there was minimal emphasis on oral health as a public health program. There was poor support, a budget of only $60,000 per year. Medicaid was not working. And there were few to no partnerships or advocates for oral health. Next slide, please. So I want you to look at this face. We cannot forget this face or this story. Diamante's unfortunate death has caused the creation of resources, education, and access to care for the children of Maryland. You know, it's unfortunate he was not the only child that died, but Maryland stepped up and addressed the issues. Next slide, please. We were fortunate to have a journalist, Mary Otto, who became interested in the story. Her articles were recognized nationally and internationally. It enraged and outraged legislators, stakeholders, and the community, which fortunately led to several actionable items to improve the oral health of children in the state. Next slide, please. So this led to the formation of the Dental Action Committee. This committee was tasked by then Secretary John Colmers to make recommendations that would improve the oral health status of children in Maryland. Next slide. So there were 7 recommendations. The first recommendation, to establish a single Medicaid dental administrator, eased the provider credentialing, streamlined the application process, and increased dental reimbursement. There has been a steady increase in the number of the participating dentists, and as of calendar year 2020, there are 4,211 dentists participating in the Maryland Healthy Smiles program. We've also seen an increase in the number of children enrolled. In calendar year, just to give you a comparison, in calendar year 2007, there were 375 children enrolled. In calendar year 2020, there were 830 children enrolled. So the second recommendation, to increase Medicaid dental reimbursement rates. So Katie has talked about this, and I highlighted this because this is one of the recommendations that has not been fully implemented. Phase 1 of the increase has occurred, but there has not been any movement on the other proposed phases. The third recommendation, to create public health infrastructure to enhance oral health safety net clinics. It has resulted in public health funding for all 24 counties in local health departments, federally qualified health centers, and community clinics. So residents in all 24 counties have some type of access to a safety net provider. The fourth recommendation, which is to create a public health designation for dental hygienists, created legislation in 2008 that allows hygienists to practice in public health facilities under general dental supervision. And the fifth recommendation, to institute a school-based oral health screening, I've also highlighted this, has been proposed but has not been adopted. The sixth recommendation, to develop a communication plan, resulted in the creation of the Healthy Teeth, Healthy Kids campaign. This educational program is administered currently by the Maryland Dental Action Coalition. And the seventh recommendation, to create collaboration between primary care practice, pediatricians, and dental providers, was created, a Fluoride Varnish program was created. And I'll talk a little bit more about that when I am highlighting the programs that we are working with. Next slide, please. So now there are these great recommendations and the momentum is high. So it is decided that a coalition should be formed, hence the Maryland Dental Action Coalition. And I wanted to take this opportunity to thank the current executive director of the coalition, Mary Backley, for her participation on the task force and the collaboration with the Office of Oral Health and the many other organizations that she collaborates in the state and across the country. Next slide, please. So now let me transition in highlighting some of the programs that the Office of Oral Health has implemented and is currently working on. Next slide, please. So our sealant program, which was started in 2008 as a CDC, the Centers for Disease Control funded program. Now we fund 10 programs throughout the state, but the program is now financially supported with state funding. We, of course, have seen a decrease in the number of children served due to COVID-19. So the numbers that I'm going to share with you are not our typical numbers, but you can recognize because of the restrictions, not being able to get in schools and children not in schools, that's why the numbers are a bit low. So in fiscal year 2021, the programs were able to treat 2,145 children, placing 5,291 sealants. Next slide, please. So our oral disease and injury prevention program, it provides funding to local health departments, federally qualified health centers, hospital programs, and other local nonprofit programs that address the oral health care needs of children and adults. And once again, these numbers are not indicative of our normal capacity, but due to COVID, this is what they were able to do, which is still an accomplishment considering the conditions. So we fund 18 programs, which resulted in 8,776 children, 8,243 adults, and 112 pregnant women being treated. And for our offsite services, it included 3,621 children seen, 2,105 adult oral cancer screenings, and 1,103 adult case management referrals. Okay, so I mentioned it earlier that the Fluoride Varnish program established was one of the 7 recommendations. This includes EPSDT, which is early and periodic screening, diagnosis and treatment, pediatricians, nurse practitioners, family physicians, and physician's assistants to apply fluoride varnish at well child visits to children ages 9 months to 5 years old. In FY 2021, there were 522 active providers providing 39,607 fluoride varnish applications. Next slide, please. So I wanted to mention this program, the Perinatal and Infant Oral Health Quality Improvement Program. That's a lot to say. So it's better known as POKI. It was a HRSA-funded program to improve access to pregnant women with Medicaid benefits and to increase the referral process for obstetricians to dentists. So as a result of this program, there was a practice guideline for Maryland prenatal and dental providers created. And currently, the Office of Oral Health, in collaboration with Maternal and Child Health Program of the Maryland Department of Health, is updating this guidance. And we plan to do another distribution to the providers. And as Katie talked about, the legislation, we're excited about the legislation that increases the coverage of pregnant women postpartum. So we hope to see an increase in the number of pregnant women utilizing their Medicaid benefit from this program. Next slide, please. So hypertension screening in the dental setting. This was a CDC-funded medical dental collaboration project to promote hypertension screening in the dental office. And it was a huge success for us. There was a media campaign, which was named 2 Minutes with Your Dentist Can Save Your Life. It was utilized on TV, radio, and bus stops. We had many success stories, but there's one that stands out that I just like to briefly share with you. So there was a patient who visited a Baltimore community dental clinic. And at the appointment during his hypertension screening, it was noted that his readings were very high. So the patient was, counseled about his numbers and told that he should see his primary care sooner rather than later. So the patient was so concerned that when he left the dental office, he did not have a primary care that he could call. So he went to the emergency room. And during that visit, his labs were taken, other tests were done, and it was decided that the patient should be admitted and have treatment immediately. So, it was a success that this patient's life was literally saved by this procedure. So, this is one of our programs that has been sustainable with our partners, and they are continuing to take blood pressure readings in the dental office. Next slide, please. So our community water fluoridation program is also a CDC-funded initiative. It provides funding for fluoride equipment replacement and inspection of public water plants. And we collaborate with the Maryland Rural Water Association and along with the Maryland Department of the Environment. And currently Maryland has 93% of its public water supply fluoridated, which is one of the highest in the country. Next slide, please. So our Regional Oral Health Coordinator Program. This is also our HRSA supported program, which supports regional oral health coordinators across the state. We have 4 of these positions, and they're located in Western. One is located in Western, one in Central and Southern Maryland, and 2 on the Eastern Shore areas of the state. The positions are utilized to build local and statewide partnerships, promote oral health integration into primary care settings, and provide oral health education to providers and patients. And we also provide oral health care kits to organizations through our regional oral health coordinators. And so an example of some of those organizations that they work with include Head Start, senior centers, primary care associations, and those are just to name a few. Next slide, please. So one of our newest initiatives is the referral to dental care for people living with HIV. And this is what I mentioned, one of the concerns I mentioned earlier. So in collaboration with the Maryland Department of Health, the Infectious Disease Bureau, we are addressing a need to increase access to care in Prince George's, Montgomery counties, and Baltimore cities. So when patients are asked what is one of their greatest needs, it is always seems to be oral health. So this program, it will include a media campaign and a referral process that will ultimately address the goals that are listed for the project. Okay, so next is our childhood obesity screening in the dental setting. This is also a HRSA funded initiative. This program addresses childhood obesity and overweight concerns in the dental setting by the staff, and we have 5 partners across the state. And when children come in, all children offered to have their BMI, body mass index measured. And those children that are identified with having elevated levels, they receive education, and referrals are provided to the families, to pediatricians, primary care, and or nutritionists. And what we're excited that this initiative will be expanded with our partners to support the Maryland Department of Health statewide integrated health improvement strategy proposal for diabetes. We're going to incorporate BMI screenings now for adults, and which will also include making the appropriate referrals and resources to help adults in their weight loss endeavors. And so we are working in collaboration with the Maryland Department of Health Office of Minority Health for implementation of this adult portion of the program. Next slide, please. So another program that we have is our Loan Assistance Repayment Program. It provides assistance to dentists who see at least 30% of their population of Medicaid patients. There are 5 new dentists that are accepted into the program annually. And currently we have participants in Garrett, Frederick, Baltimore, Hartford, Queen Anne's, Talbot, Charles, Prince George's County, and Baltimore City. And as noted, each of the dentists receives $25,000 toward their loan repayment annually. And it's for 3 years. They participate in the program for 3 years. So Katie did such a good job of talking about the adult dental program. And I want to be cognizant of time. We can skip my next 2 slides and go to my last slide. So I did want to mention that I didn't include a slide to discuss our school screening of kindergarten and 3rd graders. This is also a CDC funded project that is done every 5 years, and we plan to do it in the spring. And it provides, what it does is provide an evaluation of the status of school children's oral health. So that is something we're planning. And I would also like to invite you to visit the Office of Oral Health website, where there's educational material requests available, surveillance and legislative reports, updated COVID information, and there's just a wealth of material on the website. And you can search the Maryland Office of Oral Health to access the site. I'm sorry, I don't have the link, but it's easy to access. So finally, I've listed a few of the challenges and opportunities we face as stakeholders. And I am really excited to work with you all through this process. And I hope that I have provided a good overview of what it is we do. And hopefully we can find ways to work together. So I think I'm right at my time. So thank you for your time and attention.
Thank you, Dr. Hughes. I'll open up the task force for questions. I have one, but I want to defer.
Okay.
Okay, hearing none, I'll ask my question briefly. With regard to the loan repayment program, do we have a sense of, and I can check out with our staff as well, how many of those providers stick with Medicaid as Medicaid providers after the 3-year program finishes? How many attrit or stick with Medicaid beneficiaries as part of their dental practice?
I don't have the exact number, but the majority of those participants, they stay enrolled in Medicaid.
Thank you. Other questions from the task force? Dr. Doring.
Thank you. The follow-up question, do they also stay in that general geographic location when they're in the loan repayment program?
We have had some participants that have moved actually even during the program, but in general, these are practices that they plan to stay in for a good length of time. And some of them are practices that they own, so they stay in that location.
Other questions? Okay, we're coming at time. I'll invite the Dean or Delegate Bagnall for any closing remarks before I make announcements relating to our next meeting and so forth.
Delegate, feel free.
Yeah, I'll defer. I think this was a good meeting.
Thank you. All right, so as some closing remarks, what we will do is we will send out the work plan with the edits to the task force members. We will revisit with you offline about the ability of folks to use a proxy or the necessity for such in order to facilitate the potential for meeting more frequently and how that would work. We will not obviously be able to institute that until after we've all convened again and gotten a sense of where everyone stands on that matter. Our next meeting is the third Thursday of November, which is November the 18th. And you will receive, we'll be in touch with all of you prior to that, but that is the next standing meeting for the task force. I would also make note for the public who are listening to this or have access to this YouTube recording that we will provide another opportunity for public comment at the next meeting since there were no solicitations for such at this meeting. And with that, I will conclude the task force meeting for October, and thank you for your time and attention.
Thank you.
Thank you.
Thank you.